Good morning, everybody. Let me first congratulate the organizers, Krishna Seshadri, Vijay Kumar, Arvind, and also Shaukat for this great meeting. And also welcome all the overseas, my friend delegates. My advice to you delegates from the overseas is take some time to see the temples and do some shopping in Chennai. Thank you. Well, the next 20 minutes, I'd like to share with you our experience on primary prevention of diabetes in India. You had just heard Professor Jack talking about the DPP, and he had just mentioned about the Indian Diabetes Prevention Program. These are my disclosures. As you know, there have been several pioneering diabetes prevention programs. The first one was actually done in China, and then the GIACO's Finnish Diabetes Prevention Program, and the DPP program in the United States, and then came the Indian Diabetes Prevention Program, and then India. And of course, this paper was published last year in Lancet. With as a multi-center study, we had several centers in Chennai to actually recruit people for identifying people with pre-diabetes. We also had a place in Visakhapatnam, which is actually a steel factory, a very big township where we had recruited people after identifying impaired glucose tolerance. So it was actually a multi-centric trial, and this is the eastern part of India. Again, it is a very exhaustive process. We had invited 8,741 people who did not have diabetes, and they underwent a post-glucose load, and of that, 5,997 were excluded, and those people who had impaired glucose tolerance, those who had a value below 160 were getting excluded. Out of the 1,832, we had invited 1,069 because 463 did not agree to participate, and of this 832 were excluded because again there were 69 who had diabetes, and finally we ended up with 537 people who were equally randomized to the intervention as well as the control group. That shows you the baseline characteristics of the control and intervention group, showing that there was no difference in any of the variables that we actually examined. So that shows the study design, 1:1 randomization. The intervention group actually had motivational text messages getting every 3 days, every 2 times a week, while the standard care actually had a contact every 6 months in order to evaluate not only the change in their glycemic control, but also in the change in behavior. We used a model which actually changes human behavior, and that's called the trans-theoretical model, or the TTM, in which we actually assume that when you tell adults with normal health to change their behavior, then they go through a number of stages of behavioral change. And this is pre-contemplation, contemplation, preparation, action, and maintenance. And of course, you can have a relapse, and then you can. The reason why you got to do this is that unless you know this, the motivational messages cannot be tailored. And so therefore, we needed to actually classify people according to the stages of their behavioral transition in order to change the messages and target them according to the stages where they were actually identified. Robust beta cells. On the other hand, those who develop diabetes, there's a drop in the beta cell secretory capacity. So if you're able to protect your beta cells at some stage, then that is the way you can actually prevent diabetes. This is the change in beta cell function compared to those people who became normal. You can know that many people became normal starting with impaired glucose tolerance, and of course many people develop diabetes, and you can see the drop in the beta cell function is a very important determinant of getting, and this is published in Acta Diabetology. We also have predictors which can actually predict diabetes: the oral dysplasia index at baseline, the delta change in oral dysplasia index, and of course NGT at 6 months. Right. For clinicians, and I'm going to give you one small clue, and that is this one. How do you actually identify people with slightly raised blood glucose levels who have a high risk of getting diabetes? Talking about insulin resistance, doing insulin levels is so difficult in many of the laboratories. Is there any way you can actually clinically do some assessment? And for that, we did this, and this is called, you do a waist measurement and look at the serum triglyceride, which can predict diabetes. Originally, this was actually done by Dupré in Canada. So what we did was, we took up hyperglycemic waist phenotype as a predictive marker for type 2 diabetes. Now what is this? The presence of an elevated triglyceride along with a bigger waist can be used as a proxy measure to identify individuals with abnormal lipid metabolism as well as insulin resistance, and that is what we did. So if you have a circumference of more than 90 in men and a high triglycerides of more than 150, a combination, this can have actually an effect on insulin resistance as well as prediction of type 2 diabetes. What is shown here is a linear regression analysis showing the association of different abnormalities with insulin resistance. What I mean is, if you take normal triglycerides and normal waist, you do not get any significant. That is the reference. And if you have isolated rise of waist, then there is definitely a association. But if you take isolated triglyceride, the association goes up. But if you take a combination of hypertriglyceridemia plus the waist circumference, that's a strong predictor or a strong association with insulin resistance. And this has been actually modeled and actually controlled for all the parameters, confounding variables as age, BMI, history of diabetes, hypertension, body fat percentage, smoking, drinking habits, and also the blood glucose levels. So a combination of raised triglycerides and enlarged waist levels strongly was associated with insulin resistance. Now the next question is, can it predict diabetes? And that is exactly. There was a 49% increased relative risk increase in those people who had a hypertriglyceridemia waist, and you can actually use it as a phenotype in order to actually identify people with insulin resistance and also to predict type 2 diabetes. So we concluded from that study, which is just published very recently in Diabetic Medicine, the HTWP phenotype, which is a bigger waist with hypertriglyceridemia in thin and lean people in India with impaired glucose tolerance, can be used as a simple proxy for insulin resistance without doing any big calculations or big, you don't have to do a laboratory test. And at baseline, it is found to be predictive of insulin diabetes. So a combined measurement is actually a strong, powerful predictor. So finally, mobile phone messaging could be a practical and affordable way to deliver lifestyle advice to delay or prevent or the onset of type 2 diabetes. The ancillary studies have given new insights into the prediction and pathogenesis of diabetes in the Indian population. This is one of the first examples of a clinical outcome using mobile technology in mHealth, because there's a big talk on this. In fact, British Medical Journal published along with that paper that this strategy was scalable, cost-effective, and has tremendous possibilities. This is an editorial written in the British Medical Journal. And of course, there's a targeted messaging intervention could be used to prevent other lifestyle-related non-communicable diseases such as hypertension and obesity, and also to improve chronic care in diabetes and hypertension. The challenge was to identify the population to whom the messages should be sent, and that's what they published. So I would like to thank the clinical team, especially the research team, which is headed by Dr. Snehalada, and also my collaborator in Imperial College in London, Professor Des Johnston. At this point, I should mention Ram here and Selvam here. Both were awarded PhD for this particular study from Imperial College, one for behavioral science and the other for biochemistry. At this point, we are now embarking a new study, because I have got another 2 minutes to talk, and that is a collaboration between Imperial College, Chennai, as well as Cambridge. One of the reasons why we are not able to get very good data on physical activity is because we are not able to measure physical activity in the human beings. One of the most difficult things to do is to measure physical activity in human beings. I'm sure you will agree with that. Therefore, in the new study, we are actually using objective measurements of physical activity, and we are also doing another thing. We are screening people with HbA1c. There's a new study where we are trying to see where we can change the HbA1c levels of the population by using a strategy of lifestyle modification using mobile phones. That study is ongoing, and the third part of that study is that in that study we have populations not only in India, but it is simultaneously done in the United Kingdom, because it is funded both by the Indian Council of Medical Research as well as the Medical Research Council in the United Kingdom. Thank you.